Welcome everyone who's here. Thanks for coming. We're nice to see you. We're happy to have Sonja and Kari here from Salus Rehab, and they are going to tell us a little bit about what physical therapy and occupational therapy looks like in long-term care. So I will turn it over to you, ladies.
Thank you. I'll just put up our slides. Can everyone see that okay?
Mine hasn't started yet.
There we go.
Yeah.
Okay. Yeah, so as Anne mentioned, we're going to talk about the role of rehab in long-term care tonight. My name's Carrie. I'm the clinical lead OT for Salus Rehab, and Sonia is the physio clinical lead for Salus, and we help to support the rehab department at both Fairhaven homes.
So, you're gonna have to go. Yeah. So we're talking a bit about the rehabilitation department. The main team members in a rehab department at most long-term care homes is a physiotherapist, an occupational therapist, and a rehab assistant. Rehab assistants are generally physio assistants and OT assistants, so they have both training. They're also sometimes SLP assistants, but in long-term care, we use them as physio assistants and occupational therapy assistants. And so we want to talk about what does each discipline do? Like how do, I know I love the pictures. They make me so happy. But so we talk a bit about what does each discipline do? Because there are some differences between each of them. And there are some similarities that are across physio and an occupational therapist. The rehab assistant, as Carrie will go through, is pretty independent of what they're allowed to do and what they can do in long-term care. So from this chart here, you're going to see we've split it up to the three disciplines. So the physiotherapist, a big part of their role in long-term care is to do a transfer assessment, which might include a mechanical lift. Is this resident or this loved one appropriate to use a sit-to-stand lift, so the lift that helps people stand up, or do they need a more supportive lift that's going to fully lift them? Or are they able to transfer with a little bit of assistance? We do a mobility assessment, which is how do they actually get around the building? How can they get around their room? How can they get around the care home? We provide education to the residents. We provide education to family members, and we also support the staff on how to safely transfer and support the residents for their mobility. If someone does have a fall, we support in doing a falls assessment. So if someone does fall, we want to assess, make sure they didn't get seriously injured. Whether they got injured or not, we also look at falls and injury prevention strategies. So what are things that we can do to mitigate the risk of getting an injury? Something like, do they need hip protectors? Is there something else we can do about their environment that can support them to be at a lower risk of falling? PTs, so physios, do some adaptive equipment. It's not the same as occupational therapists, but we usually are prescribing things like walkers or a cane. The more detailed or in-depth equipment is usually on the occupational therapist. I'll let Carrie kind of go through that.
Yeah, so as Sonia mentioned, there is overlap between physio and the occupational therapist as well. So in conjunction with the physiotherapist, we're often looking at the mobility and transfer assessments with the physio. And then if residents need more supportive seating or more adaptive seating like the wheelchairs, then that's when we're more involved. Generally, we're doing our wheelchair assessment and then following up with families if they need something more specialized. This can also include seating. If people have wounds or they need more support as well, then we follow up and do a lot of the wheelchair prescriptions there. Then we also are involved with the falls prevention as well. So we look at the environment as well, looking at falls, how we can help mitigate the risk of the injury. So we look at chair alarms, bed alarms. We can sometimes look at fall mats as well, hip protectors. And then a big one is looking at if restraints are appropriate. And that we'll do in conjunction with the physiotherapist as well. And like the physio, we also look at the education to the residents, the family, and also the staff. Another big thing that the occupational therapist is also involved in is wound management. So we'll work with the nurses and the whole interdisciplinary team to see how we can manage someone that might have developed a wound. And then our rehab assistants, so they work underneath the physio and the occupational therapist. So they can't make any clinical decisions, and they're getting the delegation from the physiotherapist and the occupational therapist. They're usually ones that are going to be carrying out the rehab programs. So if there's an individualized mobility program or walking program that's prescribed by the physiotherapist, they will be the ones generally carrying out the program. The other big thing that they do, and they help us therapists as well, is try to help maintain the equipment inventory. So all wheelchairs, walkers, mattresses, cushions, anything you can kind of think of that's in the facility, our rehab assistants help us maintain that inventory and keep track of where everything is. And then if the facility has a rental program, they may also help with the coordination of the rental program.
So all of this stuff is very cool, but how do we actually support our residents in care? So supporting their dignity, their comfort, and their independence. Our big overall goal is always to maintain our safety of our residents. That's one of our biggest priorities. So making sure that they are performing safe mobility and their ability to move around our care home independently as much as possible. Reducing falls and injury risk, there's a limitation to this. We want to reduce the number of injuries that someone does have as a result of a fall, but we're not always going to be able to stop people from falling. So inherently in long-term care, we do have a lot of residents who do fall. Our big overall goal is how do we mitigate the risk of them being injured from that fall? Managing their pain, so managing pain through movement, different positioning that we can offer our residents, and also helping residents maintain some confidence in their mobility. Oftentimes, if someone has a fall, they lose their confidence in their ability to stand up. They lose that confidence in their ability to walk again. So we do really work with our residents to ensure that they are able to walk and they're able to do those transfers safely and more independently, but we're building that confidence in them because it is often quite scary if they do have a fall for them.
Yeah, and then from the occupational therapist side, we're helping to enable residents to do as much for themselves as possible. So we look at the resident and we kind of look at the environment to see how can we adapt things so people can still do the things that they want to do. And that's largely a lot of that has to do with the mobility. We also help to improve comfort through proper seating and positioning. So if someone needs more support or they're not comfortable in the chair, we'll look at different options there. This could also be if someone develops a wound, then we'll also look at different seating to help support that as well. And then we also adapt the environment to reduce frustration and dependence. So we might be working with the resident to see if we can teach them wheelchair propelling so that now they can, if they've changed their mobility, they can no longer walk and they're using a wheelchair. Now, hopefully, we can still get them to propel so they're not stuck and depending on the staff to get them around the facility. We also look at restraints too to determine is this the best option for a resident? Generally, we try to go towards least restraint. So we'll have a whole assessment and then have a discussion with family and the whole care team to decide if that's the best way to go to support a resident. And then the rehab assistant, they help to provide consistent practice of therapy programs because they're the ones that are mostly carrying out the therapy day to day. They also help to maintain the progress between assessments that we generally do. And then they encourage the participation in daily activities.
So we get some questions that say, when should my loved one be assessed by a physio? When should they be assessed by an occupational therapist? Like which residents are appropriate for each discipline? So from a physiotherapist standpoint, on admission, all residents should be assessed because we want to determine how do they physically get out of bed? How are they going to get to a wheelchair? How are they going to get on and off the toilet? So what is their baseline when they first come into the care home? What does their transfer look like? And what does their mobility look like? We often get referrals from the nursing staff if someone has a fall and they're suspecting, okay, this could potentially be a serious injury. The physiotherapist is going to get a referral saying, hey, this person had a fall, please check their notes. They might have gotten injured. The physio is going to do their assessment at that time. If someone does break something or there's a new injury that's limiting their mobility, same idea, the physio is going to do a specific assessment to ensure that we're trying to get them back to their baseline ability. If there's any change in their pain, if we're noticing any strength changes, or as Kari mentioned, we're considering a restraint, those are things that the nursing staff will refer to us and say, hey, this person's had a change in their pain, they've had a change in their mobility, or they've had someone's requesting a restraint, whether it comes from the family, the resident themselves, or any of the interdisciplinary team members, we're going to evaluate that resident to see if they're actually appropriate for that. Care conference notes, I feel like a lot of family members have attended care conference, so we do check all of our residents before care conferences happen to make sure that they're actually at their baseline or has something changed that time. I think I went through that kind of quick.
And then same thing when are we an occupational therapist? So generally, if there's a change in mobility status, we'll often be involved, especially if that includes needing a wheelchair or other specialty equipment. Same thing, if there's a wound, then we usually get involved as well to look at what is the cause of the wound and how can we try to mitigate and help with the healing process. So we'll look at positioning, we'll look at equipment, we'll see what else there is involved to try to reduce those factors that are contributing to the wound. So generally, equipment is required. The OT helps to support the family through the, purchasing or renting equipment. We usually do this through equipment vendors who come into the facility, and the OT will help you navigate the whole process of getting the equipment that is recommended. And then if you have funding, so extended health benefits, Veterans Affairs, Ministry, First Nations funding, any other kind of funding support, we will also help you navigate that process and get the documentation together to support you so you can apply to those funding sources. Generally, you'll need a justification letter, you'll need a doctor's note, and then the quotes from the vendor. So we'll help you get all of that together so you can send that off for funding approval. And then we are largely involved in the falls management as well, including the restraints. So as mentioned, we try to do least restraints. But sometimes if someone is a high falls risk, we have the whole discussion with the interdisciplinary team and family and kind of figure out goals and what's the best thing for the resident. And then we do review at care conference as well, or on a referral basis. So the nurses will refer to us if there's any concerns, and then we can assess as needed.
Oh, the
And then the
assistance.
rehab assistance. So after complete physio assessment, all residents are eligible for a mobility program. So there is a criteria that we do look at before deciding if a resident's going to be put on a program. So they should be able to follow one-step verbal commands or physical gestures. That just allows us to be able to carry out a program with a resident. If a resident can't really follow directions, then it's going to be hard to do more active stuff. Some might be on a passive range of motion program if they've received like Botox injections. They might have that to help do some of the stretching to manage after those injections. And we also have a criteria where the resident needs to be cooperative and consents regularly to participation. So although we'd love everyone to participate, if a resident is refusing, they have the right to refuse, and we can't always push it if they're consistently saying no. And so generally the goals of the program, we're going to work with the with the family. And some of the goals that we look at are to reduce falls risk and injury risk, to maintain or improve transfer mobility status. So if they're able to stand, then we'll try to maintain that through standing exercises. And then we'll look at the mobility status. If possible, we'll try to work on maintaining someone that's walking, for example. And then also the other goal is to promote general health and wellness with our residents.
So most of the residents in long-term care and at Fairhaven receive rehab or the mobility program 2 times a week. That's kind of the limit just based on the staffing and the number of residents we currently have on our list. We are very clear about if someone wants additional services. So if they're looking for 3 times or 4 times, we can provide private services, but there is a cost to those services. And even though that Salus is available to provide those services, we do recommend families reaching out to anyone in the community that they would want to come in. So you don't have to use Salus as that company, but we are within the building. It's easy communication. it's continuity of care, and the rehab assistants know your residents well. At the same time, there's no obligation to ever just use Salus. We do have a few clients right now, I believe, that are receiving, do you want to go to the next one?
Yeah.
I think it's massage therapy. And then we also offer massage therapy, physiotherapy, and kinesiology services, but that is a pay per service. So they're usually anywhere from 30 to 45-minute sessions. They still have to have an assessment by a physiotherapist, and then the program is done by the rehab assistant.
Hmm.
I don't know. I think that's all we
Oh,
have.
am I still there? Yeah. Oh, there we go.
Thank you so much for
And
your
then if
time.
there's any questions, yeah. Maybe I'll stop sharing, then we can see all the faces. And then if you guys have anything, any slides you want to see again, we can always put it back up.
That was great. Thank you so much. That was a lot of good information there. Does anybody have any questions? Anne,
Yes,
nice
thank you.
to see you.
Yeah, good to see you all. Sorry, I was a little bit late. I got mixed up between 6:15 and 6:30. Don't know if I missed a couple of the beginning slides. But my question is around RMT is or even like sometimes if there's like kin students or RMT students, would we as Fairhaven Vancouver Lodge, I'll just say just because mom's there, would we be able to like have students come in that are not fully trained, but as long as it's in a safe environment?
I'll pitch in for the kin students part of it. Joy, I'll let you jump in for the massage therapy. So we do often take rehab assistant students that come into our program. So right now, I think, Carrie, correct me if I'm wrong, we have 2 or 3 students, and they three, and they have to be supervised by the PT or the OT. So they are not allowed to kind of come into Fairhaven and run amok. We do need to make sure that they're following the programs, and there's some limitations on what we're allowed to assign them, just because they're not fully completing their program, and they're not like, they're still under the PT and OT license, and they're still not registered, or they don't have their full completion of degree. So from a rehab assistant standpoint, they're wonderful and they can help us, but they always have to be with a PT, OT, or kind of assisting the rehab assistant. So there are some limitations that we have when we're bringing in students. RMT students, I think, are a different beast altogether, where, and Joy, please jump in if I'm saying anything out of turn here, but RMT students, it has to go through their college. They have to be assigned to our care home. And then what happens is there has to be an appropriate group of residents that are eligible to be treated by massage therapy students. So it's usually based on the college of who's sending the students. They also can't be first-year students. They have to be, I believe, second year towards the end of their program students that are allowed to even participate, because there's just so many risks involved. They don't have a license to fall back on. If something happens, then the risk is on us because they're treating our residents.
Okay.
I don't think I have anything to add, Sonja.
Yeah.
You captured that there. I know that, Fairhaven as an organization, we really want to support training of students of everything. You may have noticed everybody, there's carried students on the floor and LPN students, and thank you for bringing the rehab students in. But we have not had any partnerships with massage therapy schools, so we haven't had that to date. And with all of our students, and just so you're aware, we sign liability agreements with all of those colleges, and there's quite a lot of paperwork in the background because of the fact that we have vulnerable adults that we're caring for.
Okay.
I will mention, if you do want massage therapy in-house, we can, like the mobile therapy services, the therapist will come to the Fairhaven home and provide the services there. Again, there are limitations with massage therapy. People think of typical massage therapy like lying down face down on a bed. Now we're going to take a resident into that situation, and how are you going to get that resident on a bed? So we have to modify their position that they're going to receive a massage in. Just be aware of that. If you do get massage therapy, that it's not going to look like a standard massage therapy session. There are modifications that have to happen specifically in long-term care. And that's why the massage therapists that we bring in, they have gone through some training on how to treat clients in long-term care, knowing that frail elderly positioning is going to be a concern. They might have to do it in a chair versus a bed. So there's a few layers that come with that, but we make sure that everyone is trained. So if you did want the therapy services, it's going to be by a person who understands long-term care.
Yeah, I was thinking of having the resident like still remain in their wheelchair.
Yeah.
Or if they are, in their bed, then they stay in their bed rather than, transferring it to how we would normally receive the treatment.
Yeah, I don't think
So,
the physios would be very happy if they're climbing onto a massage therapy bed. I don't think that would fly very well.
No, it's hard enough for the rest of us too. So, okay, thank you.
Yeah, no problem.
Were there any other questions that anybody had? No? Okay. Well, then I will say thank you to Carrie and Sonja for their presentation today. It was really lovely to see you.
Yeah.
And if anyone has any follow-up questions that comes to them later on, you can send them to me and I will send them on to the ladies and they can give an answer for you.
Sure, thank you.
Great. And
Thank
if you want to stay on, everyone else, we just, Joyce has an announcement she wanted to share.
Okay.
Sounds good.
See you.
Thank you.
Hi, nice to meet everybody.
Very interesting. Thank you.
Thank you.
More of an announcement, just kind of a notice and change, and Anne, you're probably better at describing it, but we're trying to shift to include families and residents in more engaging activities. So I know Eric was a real advocate for shifting to like a family circle and having more in-person events on site. And so I've asked Dawn, our spiritual care coordinator, in partnership with Dana, our recreation leader, to host combined resident council and family council drop-in sessions. So we're going to shift to that and move away from the Zoom in the evenings. And I recognize it's always a challenge to find the right time of day. And it's never, some people are working, some people like the evenings, other people don't. But I really wanted to try and support more in-person activities on site. So we're shifting away to that. During those sessions, though, if topics for education come up or, we want Dawn and Dana to be there just to spark conversations and promote people getting to know each other and getting to know other residents and other families. And if topics come up that would be helpful for education, we can come back to, a more town hall format like this, or we can do some education. So, Anne, did I capture that okay? What have I missed?
Yeah, no, that's great.
Yeah. So I know that we've got the spring fling planned. I get those words coming out of my mouth.
It's a hard one.
The spring fling is planned for the second week of April, and we'll go ahead with that. And that can kind of be a taste of what it's like to come during the day and just have a drop-in and a visit and a collaboration. So we'll hopefully build on that. But I just wanted to share that a little bit.
Yeah, that sounds good.
Okay.
Yeah.
Good.
Yeah, this was kind of based on some conversations that was on points raised at our last family council meeting, where there was a lot of discussion about a different kind of format. So I took all the good feedback I had received from the folks who were at that meeting, and we kind of came up with a new plan.